Good morning. It is Thursday, October 21st. Welcome into the Morning Medical Update. We are live inside the Dolph Simons Family Broadcast Studio. Thanks, everyone, for joining us today on Facebook and YouTube. Dr. Stites is here with us today. How are you?
I'm good.
We're talking about chronic pain.
Yeah, many people see me as a chronic pain
in
their lives.
I knew that was coming.
I don't think there's a cure.
Okay,
there's
we'll
my
see.
favorite.
There might be a special device.
They do.
Just for you. So.
I did it.
All right, so chronic pain affects about 50 million adults every year, and you or someone you know deals with this probably daily. Now there is a new device recently FDA approved helping some people take the pain away, and it's all thanks to a trial conducted right here at the health system. But first, Medical Director of Infection Prevention and Control, Dr. Dana Hawkinson, joins us this morning. How are our numbers?
Yeah, numbers are holding steady in that low 20s area, so 22 active infections, 9 in the ICU, and 4 of those patients on the ventilator. We still have 25 patients who meet that recovery period. Hayes has 8 active infections and 4 in that recovery period as well. So we here at the health system have a total of 47. Steve, the numbers have stayed pretty stable this week. Hopefully we will see a downtrend soon.
I hope so. They have been stable because last week we're in the teens, This week we're in the low 20s. It's all going to be what happens when people take their masks off. They go inside, and how well we do. I'd love to see mask mandates continue. Don't know that we're going to be able to get that done. And I think the questions are, what will schools do? University of Kansas has relinquished their mask mandate. Mizzou did a few weeks ago. And I think it's hard, right? As numbers fall, do people still want to keep their masks on all the time? And it's difficult. So I think that when people go indoors, they don't have masks on. That's going to be the next big challenge we face, and we'll see. What we have to hope is there's enough vaccination that's occurred, and maybe there's going to be immunity from people who've had and recovered from COVID-19 that will be okay. But that'll be the challenge. And we're seeing some information coming out of the northernmost counties in the northernmost states, where they're starting to see some increases even up in the Northeast, whereas before they had been a little protected. So we'll see how this goes.
But do you see a connection between when we see cases go down, that people feel more comfortable taking off the masks?
Yeah, you bet they do.
Okay.
You bet. And I think people will relinquish mask mandates. It's just harder to get them politically, right? And I get it. Businesses and companies need to be open. They need to be able to go full throttle, especially as the Christmas season hits. Gosh, I want them to see us do it safely.
I know. All right.
Get vaccinated. We'll take care of you. Get vaccinated.
All right, let's get to some reporters. Any on the line today?
Hey, good morning. Cody Holyoke with Channel 9.
Hey, Cody.
Hey, just a little while ago, Pfizer came out saying that there was the phase 3 trial that a booster of their coronavirus vaccine was found to have a 95.6% efficacy. And I'm curious, I know yesterday Dr. Stites touched on this about asking or recommending, he said, to patients who took the J&J vaccine that they get a Pfizer or Moderna booster. And I'm curious, does that go the other way? You touched on it very little bit. Should people stick with Moderna or Pfizer if they had Moderna or Pfizer as far as a booster is concerned?
Yeah, that's a great question. And let's try and pull it apart a little bit. So if you've had the J&J vaccine, are you better off getting a Pfizer Moderna? This all hinges on whether you believe antibody titers are indicative of how good your immune response is to COVID-19. There is early information that suggests that's true, but there are multiple other layers of your immune response beyond that. But there is indications that as go your antibody levels, that may be an indicator of your other levels of immunity. Well, if you look at the data after J&J vaccine, if you got a J&J booster 2 months or more after you've had the initial shot, then what happens is your titers go up by a 4-fold level. If you had the Pfizer vaccination, they went up about 35 or 40 times, and if you had a Moderna vaccination after J&J, they would go up about 70 times. Now that's a full dose Moderna. Just to make this really confusing, what was authorized was a half dose of Moderna, not a full dose of Moderna. So we don't have that information about a half dose of Moderna after the J&J vaccine. We have full dose data. Having said that, the half dose of Moderna still has more mRNA in it, Hawkeye, than does the Pfizer vaccine. So, those two are probably going to be, I'm going to guess, are going to be roughly equivalent.
Yeah.
If I'd had the J&J vaccine, I would probably want to get the additional antibody boost because that may track, so I'd probably want an mRNA vaccine. But if you step back and look at the real world data, the J&J vaccine is still doing a really good job of protecting against severe hospitalization and death. So I think you can go either way, but I know, for example, in one of my transplant patients, her transplant center was very clear. Once you've had J&J as a vaccine, we want you to switch to a messenger RNA vaccine now. And that's probably where I would land on people who are more severely ill. Now, the flip side of that, I don't have any evidence for. So I can't even comment about if you've had a messenger RNA vaccine, should you switch? I don't know the answer to that. Here's what I'm going to tell you I'm going to do. I've gotten the Moderna vaccine for the first two. I'm going to get the Moderna booster. Yeah. I think the data on it is outstanding. That's where I'm going to go.
Yeah.
Hawk?
Yeah, I mean, I would agree. I think that's the big thing is the caveats to understand is these are opinions based on the totality of the data, but what is that totality? There's certainly a paucity. There's a little amount of data about this, and there is the basic lab research, just as you said, that show those higher antibody levels. There's also early preprint laboratory data showing maybe increased T-cell responses as well, but how does that correlate clinically 1 month, 4 months, 6 months after you get that dose? So I think really there's not going to be a lot of guidance on what to do specifically. It will be vague, other than saying that it is safe to go ahead and mix a adenovirus vector, which is the Johnson & Johnson vaccine, with the mRNA. I think a lot of people will elect to get the mRNA vaccine. I think that's good. I think that will continue to offer protection, and we will just, again, further wait to see what the final recommendations would be.
So I just say, Cody, thanks for coming out of the gates with the heart. You could have said, how the Chiefs going to do? What about the Royals' good arms? Right. Hey, are the Symphonies playing John Williams and the Pops on Saturday night? That's going to be cool. But no, let's hit the
These are the questions that people want answers to. But I mean, as you get through all the medical terms here and all that jargon, basically, what should somebody do? I know Doc Hawk just said the guidance will be vague. That's tough in a pandemic that, when the government has had messaging issues the whole time.
Well, you're right, Cody, and I'm teasing you, but you did ask the right question. So here's what I think. They're doing mix and matching because they're letting people make a choice because all the data is good and they want to get as many people vaccinated as they can. So what they said about J&J is if you're concerned about some of the potential side effects around, the clots and stuff like that, even though that's minimal, they want you to still get your booster. And so they're going to tell you, go get anyone you want. And because there are some places that don't always have the best choices, so it's sometimes harder to find in some areas of the country the exact same shot as you got initially. So they're saying to you, look, it works. Just go get whichever one you want. And so I think that's actually the real recommendation. The real recommendation is that all of them are good and all of them are safe. I personally believe that the messenger RNA vaccines, my gut instinct is that they're a little better than the J&J ones. I can't prove that to you right now. This is my gut feeling. And as I said earlier, I was blessed. I got the Moderna vaccine back in January and early February. I'm going to get the booster dose of Moderna when it's my turn, and I think my turn is coming up soon. So I'll get a half dose of the Moderna when it's available to me. And I would encourage anyone out there, if you should feel completely comfortable getting the same one you got originally, including if it was J&J. And I think you could feel comfortable if you want to switch. And so if for some reason you want to mix and match, go right ahead. But if you asked what's the best recommendation, we're not sure. We're just not sure. What we can tell you is they're all really good. And so do with what you feel like and do what's available to you most immediately. It is interesting that, as we say, and I would say, and honestly, if I'd had J&J, I'd switch to an mRNA vaccine. But there is some evidence in New York State, Hawkeye, where they did a small study of 9 million folks or so, small study, but 9 million, suggesting that J&J's outcomes are outstanding. And so even in the age of the Delta variant. So there's evidence for all three of the choices. And what I would just say is that you should feel good about whatever booster you get. If you did well with the first shot, you can feel really good about getting that booster. Because the reality is they all work, they all do a good job, and what we're trying to do is we're not going to do a lot better against severe illness and death in most patients because we're already incredibly good at it. What we're really trying to do is help prevent disease transmission. That's really what the third booster is about. It's more about stopping disease transmission as much as it is about giving you more protection, because you've already got great protection after the first series of shots, Hawk.
Yeah, I think that's exactly right. You know, we want people to become maximally protected. All the vaccines we know continue to protect very well against hospitalization, severe disease, and death. Really, if you fall into that category of having been a person that is recommended for that extra dose or that booster, just go get that booster. I don't think it matters which one you get, whether you got Johnson & Johnson first and you're going to get that for your second dose, or get an mRNA dose for your second dose instead. Same thing goes with if you got the mRNA dosing the first time, switching to Johnson & Johnson. Again, we don't have a lot of data about that, but getting something is going to continue to give you protection.
I think the bottom line is this: go get what you're comfortable with. Just go get it.
Yep.
And they're all going to be
Yeah.
really good. So take the one that's available to you and the one you're most comfortable taking. They're all good.
Thank you.
Other questions? And you're going to get your booster here, right?
Yes, ma'am. I'm going to get my influenza shot on this.
They told me
this
I
show.
could do it. They told me I could
You're
give
going
you
to get it back?
Yes, they said
Wait
I
a minute,
could give you the
Hawkeye,
shot.
did you give that? Is that what you said?
I
I'm
have
not
been
getting
given
it from her.
I'm gonna
no.
get our
special
paid doctor here to help me
authorization
if
to
that's
give it
gonna
to
be
you
true.
guys, just for fun.
So,
just
Hawk,
see how I do.
are we going to get our influenza and our booster on the same day?
I'll have to think about that.
That's whatever you tell me to do. I'm going to do right
I
here
had someone
on
just
the program.
ask on the feed if you two have gotten your flu shots, which is no, and you're going to do it here on the
We're
show.
gonna do a show
You're
next
holding
week.
off a little
Next
bit,
week.
right? Why
Yeah,
is that?
we're just waiting a little bit longer. I wait a little bit longer till the end of October, early November, just to have that 6 months, that better 6 months of immunity, which is a little bit better for influenza vaccine. We know that immunity wanes a little bit quicker throughout the season, so really like to wait for that later November. Later October, early November time period.
So next week, Wednesday, open mics, Dr. Stites.
Yeah.
Let's get our influenza, all right? And then
Yeah.
maybe a week or two after that,
Perfectly
whenever
fine.
whenever our time's up, we're going to get our
Yeah.
boosters right here.
All right, let's do it. All right, we're going to get to our Facebook and YouTube viewer questions here in just a bit. But for diabetics, it can be a lifetime of keeping their A1C and blood glucose numbers in check. Many often feel pain in their feet and in their hands, and that is called neuropathy. And one man has been living with it for years.
It just hurts even to walk around in your home. And lots of times you'll be furniture hopping when you're moving around.
And to help ease that pain, he took part in a study aimed at helping diabetic patients with neuropathy. This involves this device, which was recently FDA approved. Alexis Del Cid shows us how it has changed his life.
The symptoms of painful diabetic neuropathy, known as PDN, can be paradoxical. Numbness and excruciating pain at the same time in the same area. An intense itching sensation with no place to scratch for relief. Or an agonizing feeling of burning, getting an electric shock, or being stung by something with no visible source. It sounds miserable, right? And yet there are an estimated 17 million diabetics in America suffering from PDN right now. The man you're about to meet was one of them. Emphasis on the word was. Winston Pelfrey is back at his happy place doing something he loves, strolling along the Missouri River at the E.H. Young Riverfront Park. Finally, he's able to enjoy his long walks again after 6 years of chronic and debilitating pain.
Sometimes I actually had to walk with a walker.
An excruciating sensation of being poked with needles radiated from the bottoms of his feet all the way up to his knees, 24 hours a day, 7 days a week. It was maddening.
Lots of nights where, with the neuropathy, I would toss and turn and my feet would just constantly moving because of the pain.
There were many nights he couldn't sleep a wink, and days so bad he couldn't even touch his feet to the ground. For an active guy who loved having fun with his wife of 44 years, attending Marine Corps reunions, and spending time with his kids, grandkids, and great-grandkids, it was a nightmare. His formerly active life was now a piecemeal of pain and pain pills. So for 6 years you were living with
pain pills to get some relief, and of course they wore off.
But then
I was browsing on the internet, and there was a questionnaire on there asking if you were interested in doing clinical trials. And I said, well, heck, I'll answer their questions. I probably never hear from them. And it was about 2 or 3 months later, I did hear from them.
it was the University of Kansas Health System calling, asking if Winston would like to take part in a clinical trial.
This is the remote that is used In a scale, you turn it on and it goes up and down.
It sure sounded strange to Winston, but heck, he had nothing to lose, so he did it. 2 years later, Winston is 100% pain-free. Simply put, he got his life back. When you wake up and you open your eyes and you don't feel pain, what goes through your mind?
What a relief that is.
As it turns out, Winston's wife also suffers from PDN, and he says now his wife is hoping that she can also get the implant for herself now that it's FDA approved, because she wants her life back too.
All right, so let's turn to our guest. Joining Dr. Sayed and me today, Dr. Dawood Sayed is the Division Chief, Pain Medicine, and Vice Chairman of the Board at the American Society of Pain and Neuroscience. How are you today?
I'm great. Thanks for having me today.
So Winston is, or was, your patient, because you said you don't see him very often because he's doing so darn well.
Yeah, he was a patient that came to us when we were doing the FDA clinical trial a couple of years ago. As he mentioned on the story, he was having pretty severe neuropathic pain or nerve pain in his feet from his diabetes. So he reached out to us to see if he was a candidate, and he was, and he's done exceptionally well. He's about 2 years out now. The study's been completed, and he's off living his life. We check on his device maybe once a year just to make sure everything's working right. But he's still my patient, but he really doesn't need me that much, which is perfect.
Fantastic. Glad he was poking around on the internet and stumbled upon that opportunity, right?
What? Yes, I was trying to get him to look at the camera.
We busted you. Okay.
That was me.
I was like, I thought you had a question. I'm sorry. Okay.
Because I'm so good at looking at the camera.
Really
I was trying to make
are.
sure Dr. Sayed did that.
Okay. No, that was a good reminder.
Yep,
okay.
there you go.
So, so this trial obviously benefited him. I want to talk a little bit more about that and the device. But what has this type of chronic pain been like for people going through this pandemic? What have you heard from your patients? It must have just added a whole other layer to it.
Yeah, I mean, I think early on it was a challenge, at the throes of the pandemic when the clinics were shut down and patients couldn't come in for their interventional treatments or their medications, et cetera. But I think overall we've been able to kind of move forward, things like telemedicine and being able to have patients come in. The nice thing about most of the pain management that we perform, it's usually done in an outpatient setting. We really don't bring them into the operating room. So we've been able to kind of move on, and COVID has been kind of minimally impactful for us, which has been nice because we don't really view that people suffering from pain really have elective kind of issues. It's really kind of urgent, and we knew early on that we really had to treat these patients effectively or they're going to end up in the emergency rooms where all the COVID patients were, and really there was valuable resources there. So we've been pretty aggressive in managing their pain throughout the whole pandemic.
How has their vaccination been? Have you had to talk people through getting vaccinated and so on throughout this last 18 months?
With the chronic pain patients, there have just been a couple of things that we've had to really kind of work through. One of those things is oftentimes to manage people's pain, we'll do corticosteroid injections. So if people have chronic back pain, knee pain, shoulder pain, they may need steroids to kind of manage their pain for a short time. There is some kind of theoretical risk that steroids could potentially decrease their immunity and maybe make the vaccine less effective. So we've been kind of just working through kind of spacing those injections out to not really affect, the maximum effect of their vaccine. It's really just some minimal planning that's really needed on parts of ourselves and the patients, but we've been encouraging really not stopping anything, just kind of moving forward.
Sure. So what would somebody do? I mean, I feel like we all have some sort of pain, and how would you know it's something that needs to be seen by you, and that there are other options out there? I think we just get so used to living with something for such a long time. What advice do you have for people that say, no, we could work through this and make life better?
That's a good question. So fortunately, when is really the right time to see a pain management specialist? It really depends on two things in my mind. Really, how long has the pain been going on for? Typically, most likely, the most common things such as like a low back injury, that's going to resolve on its own after a few weeks. So if you have an issue in your lower back or with nerve pain that lasts more than, a month, it's maybe time to start seeing kind of a medical professional outside of maybe your primary care. And the other thing is the intensity of the pain. Sometimes if the pain is so intense that you can't really get out of bed, maybe it's the time to really seek care and really not wait, 1, 2, 3, 4 weeks.
So let's talk a little bit about the trial and the device involved in this. So just walk us through that.
Yeah. So what we were doing here with Winston was looking at kind of a device called a spinal cord stimulator. So spinal cord stimulators have been around for several years, but really this was looking at a new indication for spinal cord stimulation, and that was from diabetic neuropathy. So we know that patients, there's about 35 million people a year, or 35 million people in the United States with diabetes. About half of those people have neuropathy. And then probably 10% of those will have painful diabetic neuropathy. And what we've typically done for them is manage them with medications, things like Lyrica or pregabalin or gabapentin. Unfortunately, those medications only work is about a number needed to treat about 8 patients. So what that means is that for every 8 patients that we prescribe those drugs, probably only one of them gets therapeutic effect. So there's a great number of patients that really have ineffective pain treatment. So what we're looking at is this novel spinal cord stimulator. So again, implanting a small microelectrode, kind of like a pacemaker. We call it the pacemaker of the spine, that sends little bursts of energy to the spinal cord to manage nerve pain in the feet. What's new about this one is that, it's called a high-frequency stimulator. The typical old-fashioned spinal cord stimulators actually cause a tingling or a kind of we call paresthesia, so kind of a buzzing-type sensation where their pain was, and it kind of masks the pain. What we found is when we tried those older type devices in patients with neuropathy, they actually kind of hated it because their feet are already buzzing and tingling. And you give them something that makes it buzz and tingle more, they're like, this is not really what I want. So the higher frequency actually almost is like a white noise. They don't really feel anything. So it actually kind of calms everything down. So they get the pain relief, but they don't get that added kind of side effect of more buzzing and paresthesia.
So does this work on other things besides lower extremity pain? Can you use it on your cervical spines for hand pain or arm pain? Or other
Yeah, I mean, we can use it pretty much anywhere where there's kind of neuropathic pain. Obviously, some indications are considered off-label and on-label. Anything in the trunk or the extremities is considered on-label, but we've used it for a variety of issues, chronic angina, a lot of different things, but it can be used pretty much throughout the body, the trunk and the extremities.
Yeah, it's a big deal because there are so many patients who fit some of that disease category, I think. What about folks who have had like head injuries and things of that nature who have a lot of kind of cranial, occipital area pain?
Yeah, so chronic neck pain, or people will develop these neuralgia type pains, and we usually have really good success with some of our interventions, injections, nerve blocks, radiofrequency ablations. But if patients really kind of have failed all of those frontline therapies, medications, therapies, etc., then doing a spinal cord stimulator is potentially an option. The beauty about this type of therapy is that we can test drive it. So everyone that gets one implanted does a trial. So we put a temporary one in for a week. So that's really and that's how we did this study with Winston. He had the device placed for 1 week. We place kind of small electrodes, and we don't implant the device, and they go home with kind of an external battery for a week. So really, we've kind of answered that question for each patient when they do that trial. And if they do well with that trial, then we know and what we consider well is, can we cut the pain by at least 50%? And if they can get their pain decreased by 50% during that week, the temporary one comes out. We have them come back a few weeks later, and we implant a fully implanted device.
Yeah, it's such a really big deal.
Well, okay, so implanted. Help us understand that for people like myself. How does it go in? Where does it go? How does it stay? Does it ever come out?
Probably the closest thing I could compare it to that people don't really have an understanding is kind of like a pacemaker. So people probably know people with a cardiac device, pacemaker, defibrillator. All the hardware and the technology looks very similar. So again, kind of implanted underneath the skin. We don't put these in the spine. The actual battery that powers the device is underneath the skin, usually somewhere in the lower back. The electrodes that actually stimulate the spinal cord, those are actually placed percutaneously through needles that are kind of threaded through the outer layer of the spine. So again, there's kind of 2 parts to the system, one where the wires are, but everything's inside, so there's nothing external. Now, you saw in the video that Winston has an external programmer, so he can use that to control the device. It kind of communicates with that area, and you can also charge it kind of like you would charge your cell phone by putting that little blue pack over the battery every night to keep it juiced up.
Oh, so you have to actually have it touching your skin to
do
that? Oh, that's interesting.
So has the opioid crisis changed your practice?
I think, the opioid crisis has completely changed, pain management, especially for people like myself, anesthesiologists that do interventional pain. I think there's been a bigger focus from moving away from opioids and looking at alternative treatments, something like Winston has done. And you could see, from the video there that, the medications really weren't working for him. And then a lot of patients have these comorbidities, and really, I think, the stigma of opioid abuse is probably a little bit overplayed, but I think really opioid side effects, people that have severe chronic diseases, lung disease, they really cannot tolerate these medications because of the issues. As a pulmonologist, what they can do to your lungs being on those areas with the respiratory effects, and people with cardiac disease and people with GI issues. So these alternative treatments that directly treat the source, I think, have been really kind of our way out of this opioid epidemic.
Yeah, I think one of the important things, and things we don't talk about enough, we talk about how long you live lots, but we don't spend as much time talking about how well you live. Mm-hmm. And I think some of the great work these guys are doing is helping us live better, even if we don't necessarily live longer. Chronic pain is just hard. And if you know people or if you've experienced it, it's just hard. So, hats off to the great work you and your team are doing, especially with trying to advance the frontier of research around chronic pain, too.
Yeah, I mean, I think that's where it all starts with, and I think that's was one of my biggest desires to come back to the university and work so we can work with very unique, innovative treatments like this. So doing an FDA study, we've never had a new indication for spinal cord stimulation in greater than 25 years. So having this new indication through the study that we did, it was a multi-center study, and our results were just published in the JAMA journal. So I think, it's really impactful to be able to do this. So then the whole community, not just pain physicians and people from all, different, aspects of medicine can see these results for chronic pain, so they can, hey, when they open up the JAMA journal, like, hey, I have a patient that I know has this problem. We know that's pretty widespread and prevalent. So now we just want to increase awareness that we know we have this effective therapy. In the study, we showed, an effective rate of about 80%. So I said Lyrica takes 8 patients, to treat one effectively. This was almost the flip of that. So 80% of the patients got 50% or greater pain relief. The other thing that was really unique here that we didn't expect was about 70% of the people had improvement in their neurological symptoms. So not just the pain, their feet kind of became alive. One of the things that actually bothers these patients, besides the pain, is that it's like this painful numbness. It's numb and it hurts. So being able to feel their feet again and kind of put on sandals and walk through the sand and not have that irritation is a big deal for a lot of these people.
So that's a quality of life thing. That is huge, right? It's really huge.
Is the idea, though, to get these people completely off pain medications?
I mean, that's our goal for most people. The reality is it really just depends. Our goal is to stabilize their dosage for sure. And if patients, so they're coming to us for a reason, something's not working. So if their medications are working, they're not having side effects, and it's doing well, they don't need a spinal cord stimulator. But say they're, I really need to come down off these medications. I'm having a lot of side effects. I'm having, issues with obtaining medications. Getting opioid prescriptions is really challenging now too. Then they'll come to us to explore these alternative treatments. So, really our goal is really to, eliminate them if possible, but get them to such a slower dose that it's really, something. Maybe I take a hydrocodone tablet maybe once every couple of weeks now when I have a really, really bad day, instead of living on them like vitamins.
Well, you and I did a story right before COVID about a gentleman who had been on painkillers for 20 years. He'd been in a car accident. So is the device and he had a device as well. And it was one, I think, that he would hit a button. Is that right? Or was this the one that it went to where he didn't have to do that anymore? But my question is it the same type of, is it one size fits all, or is this specific device for neuropathy and then there's other type of devices for other type of pains?
It's completely different for whatever type of pain you have. There's probably now like 17 different types of devices for, different types of pain relief. So the field has kind of exploded. We call this field kind of neuromodulation, so neuromodulating the spinal cord. So there's different types of devices. So I think that's another advantage here, is that we pretty much are experts in every one of those devices. It is not one size fits all. Mm-hmm. Sometimes you'll see people get this, I got this device and it didn't work, and you kind of review, well, actually, it kind of probably wasn't the right device for your type of pain. You really actually needed this option. For instance, someone like Winston, he really needed a high frequency stimulator. He didn't need a conventional stimulator because he probably wouldn't have had good results.
Well, that's good to know.
Yeah, so that's why you want to come to a place where a lot of experts are, wherever that may be. But as you look down the road, what's the next big development coming?
Yeah, I mean, I think, neuromodulation, spinal cord stimulation is obviously a big one. So being able to kind of, hijack the spinal cord and where those pain pathways are. I think the miniaturization of those devices, a lot of these things now are kind of going to be, really the size of, have a very low footprint. So I think that's going to be exciting. I think there's also things where, there's going to be injectable devices, that we actually just kind of inject into the spinal cord and really not really need an implant. So I think when you look at, this research and all the things that are being done, the future is very excited for people suffering from chronic pain. And I think, it's coming quicker than we think. Artificial intelligence is another big thing. We're involved in another clinical study right now in which actually a spinal cord stimulator has AI embedded into the electrode. So instead of having the patients having to adjust it like Winston does, it actually senses what's going on in the spinal cord. So it's automatically adjusting based on the algorithm it's producing. So there's really a lot of interesting stuff.
We are going to have microchips injected into us at some point.
You do all along.
Only intentionally.
Yeah. So that's where they're at. They're not going to Ford. They're going to think, yeah, that's right.
Okay, I've got a bunch of questions coming in for you. So let's just jump in. And Debbie has a question, and I'm just going to get, how I love big words. Dr.
Yeah, you do.
I do. So Debbie wants to know, does the stimulator work for spondylosis?
Spondylosis.
So spondylosis, so that's, kind of a layman's term for kind of arthritis in the back or degenerative changes, for sure. That's really kind of the original intention for spinal cord stimulators. Is probably the number one reason we implant them in our spine center is for chronic lower back pain. So again, Absolutely, it can be, but the one thing is that we'll always make sure, because everyone's a little bit different, is that we trial the device. So, if someone has spondylosis and we think it's, appropriate, we'll do a trial, and if they do well, then they'll move on to the implant. So a number one indication for spinal cord stimulation.
So Judy says her husband gets injections here about 4 or 5 times a year for lower back pain. Would he be a candidate for a device like this?
Yeah, I think, again, the two main things that we look at if someone's going to be a candidate for a spinal cord stimulator is, one, is what they're doing right now not effective. So if the patient is not, satisfied with the relief they're getting from the injections, or really not satisfied with getting injections continually, then we can definitely evaluate them for them. But, we really like to see a bigger component of nerve pain versus kind of arthritis and degenerative changes, so it can work for those. That's where the trial really kind of figures out, who's going to be the ideal candidate.
Adrian asks, would this be a treatment for fibromyalgia?
That's a tough one. So again, as I mentioned, typically we want to see some sort of focal neuropathic pain. My feet burn, my foot hurts, it's shooting down my arm. Fibromyalgia is pretty challenging because sometimes patients, have pain essentially in their whole entire body. So spinal cord stimulation for fibromyalgia, in my opinion, is not a good indication.
Kevin says, neuropathy from malnutrition disorder. Is this device available?
It can be. Again, the one thing I always want to be careful with is, you always got to correct the underlying disorder first. So if the malnutrition's been improved and they have good nutritional status and they've seen, their internist and gotten all that corrected, and they still have kind of severe chronic neuropathic pain that's from, an insult, then I think absolutely it can be on the table. But we always want the underlying disease being addressed first. We don't really want to treat the disease of malnutrition with a spinal cord stimulator.
Any advice on how people could just stay out of your office in general, where they just don't have these kind of pains, or is it kind of inevitable eventually it's going to happen somewhere?
That's a very good question. I think there are things that we can do. There's some things that are out of our control, but I think diet, exercise, being active, being healthy, trying to avoid, high stressors in your life all help. I think those things, so that if you do develop an injury that, can cause pain, you don't drop into kind of that chronic, severe, debilitating pain. People that already have a high level of function, say if they have something very common, herniated disc in their back, if you can rehab and you have strong core and those types of things, you're eating healthy, those people usually recover after the injury's over. Now, people that potentially already go into something with, not having a high level of health, say they haven't exercised much, they have a weak core, they're not eating right, they develop a nerve pain injury, sometimes those patients will flip into chronic pain. So kind of doing everything you can do to optimize your own health is probably the best advice I can give you.
The guy with chronic low back pain, I'll just tell you that core stuff is incredibly important, and also knowing what kind of stretching and other exercises to do to help protect yourself, making sure you have, one of the big things I always tell my patients when they come in with these complaints is you got to make sure you have good footwear. And if you don't change your tennis shoes every 6 months or 3 months, whatever, depending on how active you are, you're going to cause more injury. So you have to take all aspects of your life and make sure you're healthy. A lot of good core exercise makes a huge difference.
Yeah, and
I love that as
earlier.
advice. I have kind of a sneaker addiction, so I'm totally with
Yeah.
that. So,
Okay,
new
me,
shoes
and
every
Mahomes.
3 to
You do
6
have
months are
good
good.
Yeah, you, me, and
Dr.
Mahomes.
Sayed's kind of a good snappy dresser. Have you ever seen him when he's not covered up his
he is a very
white
snappy
coat?
dresser. I would aspire to be that. But, when you look like John Lithgow, you can't. By the way, we're going to run a survey at the end of the day. Who do I look like, Dr. Drew Pinsky or John Lithgow? We need people to respond because we have a little bet. We have a little bet between Jess and I which way this is going to go. Oh, geez, here we go.
We're way ahead of
Drew
you.
Pinsky, John Lithgow, vote for Drew.
We have this all covered.
Or Daniel Radcliffe or Joe Montana.
Or who is it you think it is? The guy, what is it, 007?
Yeah, that Radcliffe guy. That
No,
guy.
what's the guy?
No, Daniel Craig. That's his name. Daniel Craig. Daniel Radcliffe was the guy who did Harry Potter. No, yeah.
Okay, we will get to that.
Okay,
just
fine.
hang tight.
We'll see
okay,
how
Brenda.
that goes. You're
Brenda-
going to tilt the scales here. That's not fair.
No,
I got there
I might
first.
get filleted on it. People
I
are
got
going to go,
there
Dr.
first.
Stites does not look like that.
John, let's go. Third Rock from the Sun alien.
And, Brenda's husband suffers from PDN. He takes oral medication, but he still complains about foot pain and numbness. Can you just comment on what that might mean? And then also wants to know if these stimulator devices are covered by Medicare.
Yeah, so I think Brenda's husband would fit exactly the patient we treated in our clinical trial. So I think absolutely that seems like a really good patient. Again, we always want to make sure that their underlying diabetes is very well managed. So, if we were implanting these devices and people that didn't have good control of their blood sugars and those kind of things, they could be at a little increased risk of complications. So if their diabetes are well managed, but they still have nerve pain from their diabetes, then I think that patient Brenda's husband would be a fantastic candidate. And then for that second question, insurance for Medicare and usually all that stuff, we haven't really had any issues. It's really broadly covered, so that's been the nice thing with this. Obviously, we can have, plans that throw little nuances at us, but overall, insurance does cover this. And with the FDA approval recently, that's helped quite a bit.
Good to know. All right. Aaliyah on YouTube is asking if another stimulator did not help for chronic back pain due to a compression fracture of lumbar 5, would this offer me more relief?
The answer is maybe. We published a study on that exact same question. It was called Salvaging Patients with Implanted Spinal Cord Stimulators. I assume she probably had the lower frequency stimulator, which causes us buzzing and paresthesia. What we did in a cohort of patients is that we actually converted them to that higher frequency, and about 65 to 70% of those patients we were able to get better pain relief with that higher frequency or converting them. So the answer is maybe. We wouldn't know until we tried.
All right. Betsy says, could this device be used for someone with AFib? Did I already ask that?
For AFib, there's a device similar to that, but that would be a question for our cardiology colleagues.
Okay.
They're really good at that.
But if you had chronic pain in AFib, you could still do it. There's no interference with that part.
No,
so
you
you
cannot.
could have both?
So it's a relative contraindication if you have both, because there can be some interference between the two. Now, in our own personal practice, it's something that we've done quite commonly across the country. We've published on that. You can have both devices. We just have to do quite a bit of kind of testing between the engineers of both devices to make sure there's no interference when we're implanting them. But we have hundreds of patients with both devices doing quite well.
Oh, interesting. Okay. So Ashley wants to know who are the best candidates for this device. She's 33, has chronic mid-back pain. I've had x-rays and scans and so on, and they all come back with no major issue, but the pain is super real. So would she be a candidate for some type of device?
I mean, I think, a device is something that we really don't jump to as a first-line treatment in someone, especially that's that young. It's a lifetime of that. Not saying that they're not a candidate for it, but typically there's 100 other interventions that we can maybe do for that patient. Now, if the patient has already, failed all of those treatments, I think that, they can be a candidate for the device. I think the nice thing about even spinal cord stimulation for people that are young is that it's a reversible treatment. So even if down the road, it's different than having, a big lumbar fusion or something like that, which you can't really take that back once you do it. With a spinal cord stimulator, if the device is not effective for them down the road, or say their pain goes away, they've done some things, you can always take the device out. It takes like a 15 to 20-minute surgical procedure to remove it, so it's fully reversible as well.
Ashley wants to know, again, remind us what's the name of the device. She wants to mention it to her doctor.
So this device is called a high-frequency spinal cord stimulation. It's called the Senza implant. That's the one we studied from Nevro. That's the one that was in the FDA-approved study.
All right, Isaac has a question. How many people have come to the pain clinic due to long COVID issues?
Luckily, that's not something that I've seen specifically for that. Now, I have, obviously, unfortunately, hundreds of patients that have had COVID and have some residual symptoms. What I found is that it's their ability to kind of bounce back maybe from issues, their ability to kind of rehab from a lower back injury or those types of things has been a little bit not where I expected it to be. And I think maybe there's some kind of residual lung injuries that happen in a lot of these people, especially the ones that had COVID that was so severe that it required them to be hospitalized and those types of things. Those patients, for some reason, and I'll defer to the experts on COVID and lung disease, but I've seen that their ability to kind of rehabilitate has been kind of down. But I haven't seen really a lot of these long COVID issues that are really pain specific, fortunately.
Yeah, I don't know, and you may have another comment. I think there is some pain syndrome associated with some of the long COVID thing, but it's more of a diffuse process, so I don't think it's going to be something that's amenable to a device.
No, I would agree with you.
Okay, I do have another question. Sorry, I'm going through these, and I don't want to miss
the other
ones.
important thing that is different mechanisms causing the long COVID symptoms versus
Mandy
what
wants.
Dr. Said's dealing with.
It's when it's a little less, and it can be joint oriented, but it can also be muscle oriented. And again, because it's so diffuse throughout your body, it's a little bit hard. It's a different sort of mechanism, and really, there's probably a different way to recover from long COVID than the device oriented ways. This is really great for more anatomic specific areas, right?
Absolutely correct.
Well, I know, but when you talk about a magic machine that somebody can have
Turn
implanted
on.
in their body and pain will go away, I think it makes people listen
Are
up.
most people happy with the device itself, or do they get frustrated by the device and having to wear it? They got something plugged in.
Yeah, that's a great question. So it's not for everyone. If a patient has trouble using their cell phone, they're like, I'm not that type of, I don't even know how to turn on a computer, I don't know how to operate my remote control at home. maybe not the right option for you. Maybe there's something else that we can do that has a little less of a fiddle factor.
Yeah.
Injections,
Fiddle
nerve blocks,
factor, I like the fiddle
ablations.
factor, it's good.
Now, if someone is, and I've been super surprised by, a lot of people just kind of say, our senior population shouldn't get these, but Winston, he's pushing 80 plus. I hope I didn't over exaggerate that, and he is all over this thing. He knows how to manage it. So our seniors really, sometimes seniors are like, am I too old for this? No, I mean
Let's be careful with what we're calling seniors.
Yeah, they've been able to manage this. The devices are pretty simple. The interfaces are really easy to use. But if but you do have to have some upkeep to it. You have to charge the device. You have to kind of come in for the regular maintenance. If someone that doesn't like coming into a doctor's office and messing with stuff and doesn't really like even owning a cell phone, maybe having a technological medical implant is not the right option.
So what would be the other option?
Well, then, there's a host of other things. It depends what the problem is. If someone has lower back pain, things like physical therapy and low-dose medications like anti-inflammatories are our first-line treatments. But if they fail those, typically patients will get things like epidural steroid injections. There's things called radiofrequency nerve ablations, a host of other things that we can do that aren't an implantable device.
All right, so that's what you're here for.
Absolutely.
Give us our load of options. Okay, Linda wants to know, would this treatment help for spinal stenosis?
It can. Spinal stenosis, again, it is a nerve issue, but it's more from mechanical compression of the spinal nerve roots. So really, instead of treating it that way with spinal cord stimulator, you can do it this way. We typically do other types of treatments for spinal stenosis. The gold standard is what's called a lumbar laminectomy, which is kind of having one of our orthopedic surgeons or neurosurgeons remove the back part of the spine to relieve the pressure. Oftentimes people don't want to do anything that aggressive, so we do have some minimally invasive options for that as well. Things like minimally invasive lumbar decompressions, where we can kind of go through kind of a small port and remove some of the ligament. And there's also little small spinous spacers that we can put in there, almost like little titanium implants that you can put in between the vertebrae to kind of lift that pressure off that. And that's also kind of a minimally invasive outpatient treatment that we'll usually reach for something like that before we go for a spinal cord stimulator.
Mandy wants to know, does this help for CRPS?
CRPS is one of the top indications for spinal cord stimulation. So that's
What is that?
What that is.
So, yeah, sorry, yeah.
Start with that.
So what CRPS is called chronic regional pain syndrome. It's kind of a really kind of funky disease. We don't really know exactly how it happens or why it occurs, but the story is usually after a surgery or after some sort of kind of, innocent type injury, people develop pain out of proportion to what you'd expect. Oftentimes it's going to affect an extremity, usually the hand or the foot or the arm or the leg. And usually they develop swelling, hair will fall off, the arm or the leg will look completely abnormal. But you'll get scans, there's no fracture, there's nothing going on. So there's something that's gone on in the neural circuitry, kind of that from the nerve from the periphery communicating with the spinal cord, causing this severe intense pain. So that is kind of a best way to kind of manage that is with spinal cord stimulation, because we know the problem is in that interaction between the peripheral nerves and the spinal cord. So kind of hijacking that with a spinal cord stimulator has been one of the most effective treatments.
All right. I have just a couple of booster questions.
Go.
Can we go for those real quick?
Yep.
Okay, so Jennifer wants to know, when should an immune-suppressed individual who has had their third vaccine get a booster shot?
Yeah, I don't think we know, Hawkeye, but I think we're probably going to say 6 months at this point, but after the third series. But it's really more of a case of I don't know than we can than specific information.
Yeah, I think that's right. That dose would be a fourth dose. So we're really considering immunosuppressed patients. And if you are immunosuppressed, you really need to talk with your physicians to understand what kind of immunosuppression and if you are going to be getting that third dose. But really, that third dose is then considered you fully vaccinated. So I think, and we talked about this earlier today, just like you said, I think we are really going to wait for some of that clinical data to come through, which probably should be arriving maybe 6 to 8 months after the third dose was authorized for that population. But until then, there is no guidance on if you need to get a fourth dose. So I would kind of hold off right now.
I think what we have to clarify too, when you're immunocompromised, let's say an organ transplant patient, you're actively getting chemotherapy, when we say third dose, that's your third in your series.
Yeah.
Right? So you get your first dose, a second dose a month later from Moderna, 3 weeks for Pfizer, and then you get your third shot in another month. That's actually a series of 3 as opposed to a series of 2. Then the question becomes, when would you get a booster after you've had your series of 3? And that's where we're saying we don't really know. I think a lot of people are going to probably say 6 months, get your next shot after your third shot in your series. And unfortunately, we got to clean up that language a little bit because it is confusing to people.
Last question is going to Dr. Sayed. Shirley wants to know, can this help RSD from a vehicle accident?
Yeah, so that's essentially the same disease that we mentioned before. RSD, that was kind of the original name for reflex sympathetic dystrophy, or CRPS. So the same answer as previous. It's the same disease, just kind of a different way to call it. So yes.
Okay, just making sure. Okay, also, Jupiter is asking, is it compatible with a cardiac pacer, or will the electromagnetic fields interfere? You answered that, but just reiterate.
Good question.
Not necessarily.
The answer is that it potentially could. We wouldn't know until we kind of tested it. We have to space them. Again, we have many patients with both, so we usually can manage those patients usually quite easily.
Lots of great stuff today, Doc. Thanks so much for being with us. Your final thoughts?
No, I think, chronic pain is, again, something that's widely prevalent. If we're not experiencing it ourselves, we all probably know someone that is. And I think, I think people we need to increase the awareness for a lot of these other treatments out there. You really don't need to suffer with this. The technology advanced so much in the last 10 years. So, really a lot of people are just kind of inclined to, like, this is just how I have to live. I don't think really that's necessarily the case. So there's a lot of new innovative treatments that we can kind of provide to these patients to improve their quality of life. Because we want to just lengthen life. We want to improve the quality.
I think what I took away is that there really are a ton of different options for people. So I'm glad you shared all of that. So
yeah, absolutely.
All right, Dr. Hawkinson, your final thoughts today.
A lot of good new information coming out about additional dosing if needed, if you fall into that category. And we're certainly going to be waiting for the advisory committee to meet and give some recommendations. And we'll be happy to give those to you once they come out. But I think we continue to need to stress that the people who haven't received any vaccination at all, that is going to be the most important thing, so they should go get their first, and obviously if they're using an mRNA vaccine, get their second dose.
Okay, great, thank you. Okay, do you want to have fun, or do you want to have a sentimental final thought first?
Can I give a sentimental final
Go.
thought? Yeah. First of all, vote Drew Pinsky. Second of all, Dr. Drew Pinsky. Second of all, when I started in medicine, you're having a heart attack, our treatment for you was morphine and nitroglycerin. There was no an early intervention. There was no, let's try and stop this from happening. There's no, we're going to interrupt the heart attack. We're going to take you to the cath lab. We're going to put a stent in you. We're going to save your life. We only let people have heart attacks. And then we had thrombolytic therapy to try and break up the clot. And then we started doing aggressive interventions. And you know what took us all there? Science. Now pain. Think about how far we've come in the management of chronic pain. All we had was before where we're just big sledgehammers. We're trying to throw stuff at people. And now we have these amazing devices. And I would just say, in terms of vaccination, man, if you can accept the most aggressive therapy for heart attacks, most aggressive therapy for pain, why not take a very simple therapy to try and prevent COVID-19 so we don't have to worry about the pain, the disability, and the long haul syndrome that goes along with it? The lesson is right here.
Love it. Well said. Are you ready for doppelganger hour?
Oh, let's go doppelganger, whatever you just said.
Okay. Now that's one word I can say.
Doppelganger. Thank you.
Okay, here we go.
Can I just say what Roy would say?
Well,
Oi!
Oi! Okay,
Oi.
so look at you. Now stand up straight. Now if Joe Montana and Jeff Goldblum and John Lithgow and Daniel Craig had a baby.
Wait. Okay, let's do it now.
Okay, now do it. Now if all these men could have a baby, they would produce a Dr. Steve Stites.
Oh my God! Really?
Now
Okay,
let's see.
which one are you
So
gonna pick?
although I do have this Drew Pinsky. This is who he thinks he looks like, and we're going to get into it.
I
Can we
believe
get
this is a fixed vote because you have clearly drawn.
But I think you
look how
actually
small
have
look
that
how
outfit.
small
First of all, do you wear suspenders sometimes?
No, never do I wear suspenders, and
then you're
neither do
going
I
to-
wear 3 pleats in my cords. Come on, really? What are you doing to me here?
You're much cooler than that. Is that what you're trying to say?
3 pleats in the cords, and my ties are not that wide. Oh, today's a little wider. Should
Okay,
be.
please
Cool.
somebody go with me on one of that. Just one vote. For whoever my favorite viewer is out there will vote one vote for the lovable, wonderful, lovely John Lithgow. Okay, Drew Pinsky,
Drew
Dr.
Pinsky.
Drew.
Oh, baby, right there.
Right there.
He's a
Okay,
little
Daniel
younger than I
Craig.
am. Daniel Craig.
I did love yesterday.
No. Yeah, Daniel Craig. Yeah.
I did like
Joe Montana. Joe Montana's pretty close.
That's pretty good. That's
not
good.
bad.
But and I did.
That's not
I
bad.
don't think that Goldblum picture looks like you, but that was pretty spot on yesterday when somebody said that you look up. I was like, okay.
And John Lithgow. Really? Oh my God, he looks like my grandfather.
No, he's not. This is a picture when he was in his mid-50s, and he's very
Well,
handsome.
Like I said, really?
All right, let us know what you think.
She needs
John
glasses.
Lithgow. Now that could be true. What do you say?
Dr. Drew.
Thank you, brother. Well done. Yeah. Woo. Okay.
I knew there.
Just
That's
saying.
the
And
winner.
And maybe that
okay.
one scene, 007, Daniel Craig's walking out of the water with
Not
his shirt
bad.
off. That looks like you too. Fred.
That looks like Hawkeye.
What?
Yeah.
Daniel
Put the shirt
Craig.
on, walking out of the water. Come on, tight shirts, really? That's you.
You know, you're my boss. So I'm really going to say you look more like a combination of George Clooney and Brad Pitt.
Oh,
my
yeah.
eyes.
Okay, no
Yeah,
wonder
you
I
guys
like
are
him.
suckers. I knew it. I knew it. All right. All right. Thank you all for being with us today and letting us entertain you for a moment there. Okay. Tomorrow we are back with Follow Up Friday. Dr. Hawkinson, Amanda Kapler is going to be here too. We're going to answer those questions that maybe we did not get to quite earlier in the week. We'll have those. Everyone have a great day, and we'll see you back here tomorrow at 8.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.